Okay, so we're going to talk a little bit about transverse tibial transfer and advanced limb ischemia. So Dr. Sia did a great job talking to us about the no-option foot and what's available for treating the no-option foot. And this is a new technique that's come out of China called the transverse tibial transfer procedure, and we'll kind of get into that. But before we do, I want to go over our objectives and then discuss a little bit of the trials that are out there, discussing the major adverse limb events that we see with patients that are no option or with critical limb ischemia. So we're going to review the landmark studies for CLTI and important clinical outcomes. We'll discuss the transverse tibial transfer, and we'll discuss clinical outcomes of the transverse tibial transfer. So important to note that, not many options for patients with CLTI. Up to 20% of people that have chronic limb-threatening ischemia are not candidates for traditional revascularization procedures due to the extensive vascular damage and comorbidities or just poor overall health. And even after successful revascularization, patients, about 1/5 of patients may still require amputation due to ongoing perfusion issues, infection, or other complications. And I think really important to keep in mind is the high event rates with surgery or endovascular therapy for these patients with CLI. And what we'll talk about is kind of the surprising data that we're seeing with the TTT procedure. So this is some data from the bypass, the basal study, 452 patients with severe limb ischemia getting either endovascular therapy with a plain old balloon angioplasty or bypass surgery. And now I'm not so interested in the comparison here between bypass surgery versus endovascular therapy, but what I'm more interested in is the all-cause mortality for both groups and the primary outcome of amputation-free survival for both groups. So as you can see in the basal study, we're seeing 36.7% all-cause mortality and amputation-free survival pooled variable here of 45%. So these are really high rates for these patients. Similarly, in the BEST CLI study, another study on bypass surgery versus best endovascular therapy with either POBA, a drug-coated balloon, atherectomy, bare metal stent, the total major adverse limb events approaching almost 50% for these patients. So these patients are complex, and they're not without adverse events after the procedure. Now, the PROMISE study, which Dr. Sia discussed, again, for no-option patients with severe disease, has less events. But again, you can see at 6 months, 66.1% amputation-free survival, the limb salvage rate 76%, which is great, thinking about where these patients' options are. But still, we're seeing a large number of patients that are still ending up with amputation and wounds that don't heal. So 76%, still about 1/4 of these patients are not healing. So a study done here by Dr. Christian's group and Dr. Farhan looked at revascularization strategies for patients with just PAD. Now, this cohort had about 20% limb-threatening ischemia, but I think it's important to know what the events are from these randomized controlled trials and the meta-analysis they published, looking at major adverse limb events as their primary endpoint. And you can see here are the RCTs that were included in the study, with a mean follow-up of the shortest group being 12 months and all the way out to 36 months. And you can see complex cohort of patient, about 1/3 only with diabetes, majority of patients with intermittent claudication, but like we said, 36 and 40%, about 38% with critical limb-threatening ischemia in this cohort of patients in randomized controlled trials. So as you can see, about 40% of the patients with diabetes had a major adverse limb event, and we're going to talk about how this compares to what the TTT data out of China is saying. So here again is the major adverse limb events that you can see, around 40%, and the amputation-free survival in this cohort, which again less complex than what we talked about before, but still around 10%. So what is transverse tibial transfer, and how can this improve upon or give us an additional option? Well, it's modified off the Elizaroff technique, and it uses the tension stress principle, where we're going to use slow and continuous mechanical tension to stimulate cellular metabolism and regeneration. The main purpose of this is to stimulate angiogenesis. So as we're familiar with the Elizaroff technique for lengthening, in this case, we're really focusing on the Elizaroff technique for angiogenesis and to improve microcirculation. So here we can see a schematic showing how the external fixator is applied. A small window is going to be made on the anterior tibia, and an external fixator is going to be applied. And then for a period, what's going to happen is we're going to insert the external fixator and then distract a portion of the anterior tibial out for a designated number of days, and then retract, or the opposite of detract, to push back this window of bone back into the anterior tibia. And this is theoretically going to stimulate that microcirculation and angiogenesis. So there's been about 18 studies that have been conducted in China looking at over 3,000 patients. All of these studies look at patients with UT scores greater than 2 and patients with very, very limited other options. And what you can see here is some of the demographics that we're looking at. Retrospective studies for the most part. All of the studies done in China, the scoring systems all greater than Wagner 2 or UT2 scoring. So complex wounds here. So here's a flow chart of how we conducted this study to get down to the 18 studies in 3,000 patients that we looked at. Now, if you think about the amputations and the major adverse limb events that we were seeing before within the vascular and endovascular data, here we're seeing the amputation rates of a pooled analysis here showing us the results of these TTT meta-analysis, showing a pooled effect of amputations to be 2%, which is much, much improved in comparison to the other data. Same thing with the healing rates. Pooled analysis of this data showing a healing rate of almost 91% across these patients, and this particular rate looks at over 2,000 patients. The mortality rate, less than 5%. So really stark difference compared to the endovascular data, and almost difficult to believe. Same thing with pin site infections. I'm sure most of us here are familiar with the Elizaroth technique and external fixator. We can always expect a pin site infection. Some studies showing pin site infections up to 50% of the time. However, with this TTT procedure, we're seeing pin sites reported in less than 3% of the patients that have had this external fixator applied. This is just some studies for a diabetic foot with Charcot showing pin site infections 20% and a meta-analysis performed 30%. So it seems that with this TTT procedure, we're experiencing much less events with the pin site infections. And this is kind of the biggest takeaway for me is the major adverse limb events with the TTT. So 17 studies reported major adverse limb events, looking at over 2,700 patients that received this therapy of the TTT. And the pooled analysis here is showing less than 5% of the patients are experiencing major adverse limb events. So this is a really surprising number as far as the potential for this particular procedure. Same thing with cardiac events here, major adverse cardiac events. Now, this wasn't reported in as many studies. However, it was still almost 1,500 patients. And major adverse cardiac events, a pooled analysis of 6%. And amputation-free survival, another major outcome for us. 7 studies reported this on over 2,000 patients, and a pooled analysis here showing 92% of patients have achieved amputation-free survival at the end of their follow-up. Recurrence rate might even be more stark, less than 1% across 2,300 patients. So really surprising data after following this procedure. When you're looking at the other data that's been published, it's nowhere near the realm. So a lot of potential with this particular therapy. However, important limitations. All of these studies were conducted in China where, it's possible that the rigor is not the same. However, I think it's really important that with this data that we're seeing, over 3,000 patients and essentially no option patients with complex wounds, is this technique really 1% or 91% healing with 1% recurrence and amputation-free survival greater than 90% for these complex patients? And I think this is a really exciting future technique that needs to be studied in a very rigorous manner for us to see, if this really is the future for potentially improving microcirculation and giving these patients another option when there are no other options. So in conclusion, like we discussed, 18 studies, 3,000 patients, all conducted in China, with some limitations being that, retrospective study design here. Some of the angiographic scoring is poor and not consistent throughout, but ultimately the results that are reported are pretty consistent and showing large improvement in comparison to some of the other CLI studies that we talked about earlier, and definitely an area where we would like to continue to see some American studies and additional RCTs to give us a better understanding of how this technique may improve patient outcomes. So thank you very much.